Hello everyone, this is Dr. Sumit on behalf of Medi Go, and welcome to today's chapter where we are going to talk about the second part of the midfacial fractures, that is Lefort 2 fractures. What you see over here on the screen is a standard Lefort 2 line. Please have a look at this. So this Lefort 2 line begins in this particular area at the junction of the frontal bone and the nasal bone. This line later on traverses laterally towards the medial wall of the orbit, thereby fracturing the frontomaxillary junction and the palate of the ethmoid bone over here, which is called the lamina papyracea. Later on, this line goes inferiorly towards the anterior lacrimal crest and goes anteriorly further to fracture the inferior orbital rim. As it goes down from the inferior orbital rim, you have your infraorbital foramens over here. This line may just travel posteriorly or anteriorly to the foramen. Why does it not go through that foramen? Because there is a very strong cortication in every foramen in the body to protect its contents so that the nerve does not get avulsed in case of a particular fracture. Now, if you have a look at this, after that, this line traverses inferiorly to fracture the junction between zygoma and maxilla over here, and this is the zygomatico-maxillary buttress. This line fractures the zygomatico-maxillary buttress and then it traverses posteriorly. How does it traverse posteriorly? Let me show it to you guys. Have a look at a Lefort 2 fracture line from this aspect, that is the sagittal aspect. Alright, so line starts over here at the frontonasal junction, comes down to the medial wall of the orbit over here, okay, and creates a fracture line between the frontal process of maxilla and the lamina papyracea. Later on, this line comes down and it traverses around the anterior lacrimal crest and then comes anteriorly to fracture the inferior orbital rim. Further on, this one over here, this is your infraorbital foramen. Line might traverse anteriorly or posteriorly to this foramen and then it fractures the zygomatico-maxillary buttress right over here, and then it traverses posteriorly along the roots of the molars. This is the pterygoid hamulus where I've marked, and then this is the junction between the maxilla and the pterygoid plates. So this fractures the junction between maxilla and the pterygoid plates, and then this entire segment of the body or the face is mobile. So this particular fractured fragment is called a Lefort 2 fractured fragment. Alright, so if you actually consider, before we even open the slides, what could be the clinical features for such a fracture? Have a look. First one, if there is a fracture between the frontal bone and the nasal bone, let's have a look over here in this particular diagram. Alright, let's make a new line for you guys. So what could be the clinical features over here? Look at this. There is a disjunction between nasal bone and frontal bone. So of course, there is going to be a nasal bleed. Secondly, it's going through the medial wall of the orbit. So obviously the projection of your eyeball and the projection of your globe will change. That can lead to anophthalmos or hypoglobus. Further on, it fractures the inferior orbital rim, which is again going to change the shape of your orbit, and that is going to look very obvious as a midfacial deformity. Next, if it fractures the inferior orbital foramen, there is going to be paresthesia of the infraorbital nerve. Alright. Further down, when it fractures the zygomatico-maxillary buttress, which connects the maxilla to the zygoma, there is going to be a change in projection of the maxilla, which is going to cause malocclusion. And further posteriorly, when it goes and separates the maxilla from the pterygoid plates, there is going to be a downward shift in the maxilla, which is going to cause posterior gagging and an anterior open bite in the maxilla. This is exactly how you calculate your clinical features based on any X-ray or any CT scan you see. But if you don't want to do that, we have a beautiful slide prepared for you right over here. But before that, I would like you guys to see what a real pyramidal fracture looks like. Please have a look at this beautiful X-ray over here. Now, have a look at this frontal bone over here, and then the next one is the nasal bone over here. They are fractured at this area. Next, medial wall of orbit fractured. Next, inferior orbital rim fractured. Next, infraorbital foramen fractured. I can safely say that this patient is going to have a paresthesia on the right side in the infraorbital nerve region. Next, zygomatico-maxillary buttress is fractured, and as you can see, there is a significant gap over here and a gap over here, so which means the maxilla has come down posteriorly, which means this patient is going to have a posterior gagging of molars and an anterior open bite. Alongside, the patient is going to have a severe epistaxis. Why would the patient have epistaxis? Because the nose is fractured. One more fact, olfactory nerve, which is a direct extension of the cerebrum, opens up in this part, and if this part gets fractured, this part is called the cribriform apparatus. If it gets fractured, you're going to have a loss of sense of smell, which is called anosmia, anosmia. That is what you're going to have in a Lefort 2 fracture. Also, there's one more very, very important detail. I'm going to zoom in over here and I'm going to show it to you guys. So, this part of the calvaria, it contains, yes, you guessed it right, it contains the brain. Alright, and brain is covered by a very, very thin layer of fascia-like substance, which are called meninges. So between the brain and the meninges, there is a fluid which is responsible for nutrition and excretion in the brain, which is called cerebrospinal fluid, or the CSF. If there is a tear in this dural layer, if there is any tear in the meninges, your CSF is going to come leaking out of your nose, and that particular clinical feature is called a CSF rhinorrhea, because it comes out of the nose. If it comes out of the ear, it will be called a CSF otorrhea. Nonetheless, this is a CSF leak, and this is what you should know about. Of course, there's a separate lecture where I'm going to talk about CSF rhinorrhea. Alright, so coming back to the revision of basic clinical features, what are you going to see in a case of Lefort 2 deformity? Number one, there's going to be a dish face deformity. Why would there be a dish face deformity? Because if you see over here, look at this particular diagram. This entire segment is going to head posteriorly under the pull of the facial envelope. You have the skin over here and the muscles which will pull it back. Once fractured, this will get pulled back and you will have a face which looks like a proper concave face, and this kind of a deformity is called a dish face deformity. Number two, you guys have been already explained, CSF rhinorrhea, of course. Subconjunctival hemorrhage. This is the white part of the eye which is called the conjunctiva, and if you have a hemorrhage over here, it will not subside for almost 14 days. You know why? Because of the permeability of this conjunctiva. So it will be there, it will be red, it will be there for 14 to 15 days. This is called a subconjunctival hemorrhage with or without posterior limits. Okay, moon face appearance because you are all swollen up. Edema over the nasal bridge and epistaxis, very obvious because you have a nasal fracture. Diplopia. Why would you have diplopia? Because you have a visionary axis over here. The axis of vision from both of your eyes is meeting at one particular focal point. But what if there is an entrapment of muscle over here? Your eye has multiple extraocular muscles in this particular area, and the commonest muscle to get entrapped over here is the muscle at the floor of the orbit, which is called the inferior rectus. If it gets entrapped, your eyeball is unable to move and you get something which is called as a binocular diplopia. However, if you have an injury to your eyeball, to your retina or your lenses, it's going to be called a monocular diplopia, which is far more dangerous than a binocular diplopia. Next thing, infraorbital step deformity. Of course, if you have a fracture line over here in this area, there is going to be a deformity and it will be called a step deformity. Circumorbital ecchymosis. Of course, if you're going to have a fracture line which is passing through this infraorbital area, you're going to have edema, ecchymosis, purplish discoloration. Why? Because when there is a fracture, there is a bleeding in the periosteum, and this bleeding will seep inside your soft tissue planes, and that will cause an ecchymosis, and that is why you might have a raccoon facies where both of your periorbital areas will turn completely purple. Periorbital edema, of course, is going to be there. Altered sensation of the cheek. Why? Because you might have an injury of the infraorbital nerve over here. Possible airway obstruction. Why? Because your entire midface is getting fractured and getting shifted behind. So of course you can have an airway obstruction. The other clinical features include malocclusion and mobility. If you want to get into the specifics of that, write it down as posterior gagging and anterior open bite. That is most commonly seen in most of your Lefort 1 and Lefort 2 fractures. So that was a basic revision of your clinical features of Lefort 2 fracture. Now, how do you diagnose it? Of course, like you have already seen, the gold standard modality is a 3D reconstructed CT or a 3D CT. You can also have a look at a PA skull image, but the images and the lines are not that clear. Why go for an X-ray when you can get your hands on a beautiful 3D reconstructed CT? Once you have had all your diagnosis confirmed, once you have a clinico-radiological correlation and a diagnosis, the next part is treatment planning. So these kind of cases are generally dealt with under general anesthesia. Okay, the intubation is generally oral route of intubation that is taken because you're going to do a lot of manipulation through the nose. Submental intubation is also a very commonly used modality. Now, look at the areas where you need to place a plate. All right, area number 1, the frontonasal area. How do you expose this area? Either a simple glabellar incision or a more difficult coronal incision. Of course, you will be shown both the images. Next thing, you want to plate these infraorbital rims, you will have to go for multiple incision in the periorbital area. Now, what are these multiple incisions? If you go through the conjunctiva, it's going to be called a transconjunctival incision. If you go through the tarsal plates, it's called a subtarsal incision. And if you go in the infraorbital fold, it is called an infraorbital incision. So incision number 1 for frontonasal area, that is a glabellar incision or a coronal incision. Of course, I'm going to show you all the surgical images. You know me, that is how I take a lecture. Next one is going to be either a transconjunctival incision or a subtarsal or an infraorbital incision. And of course, to expose the zygomatico-maxillary buttress, you're going to need an intraoral incision. So what are the 3 sites that you're plating? Number 1, frontal process of maxilla or the nasofrontal area. Second, inferior orbital rim. And third, zygomatico-maxillary buttress. Would you like to see how that looks like? Let me show it to you guys. Alright, but before we get to that surgical exciting part, let me tell you how our ancestors used to treat these Lefort 2 fractures. There was something called as a cranio-maxillary suspension, where the calvarium was used as a leverage. There were superficial screws drilled into the calvarium. A halo ring was put out on the calvarium. Wires were extended and the midface was anchored through the arch bars to these devices. These are obviously outdated modalities now. And now again, let me show you the first part of the Lefort 2 plating, that is how to plate a frontomaxillary area and a nasofrontal area. Look at this. The incision, these are cases performed by me. So the incision, let me give you an orientation what exactly this is about. Alright, so the incision is a pre-existing laceration that you see over here. Now if you see eyeball number 1, eyeball number 2, we have completely opened this area, and now what you see over here is the frontal and nasal area. Look at this. This is the frontal bone. This is the frontal process of maxilla, both the sides, and this is the gap between the frontal and nasal bone. What have we done? We have reconstructed the frontal bandue and we have placed 2 plates over here. So of course, that deals with this particular part of the plating. What about these parts? Let me show you how these parts are dealt with. Number 2, please have a look at this. So if you want to deal with the inferior orbital rim, this is an infraorbital incision that I have taken over here. Okay, and this is a small mini plate that I have placed over here on a fractured infraorbital rim. And now, of course, the third fracture, would you guys like to see? Of course, I know the answer. The third fracture, this is how you do it. Of course, we have dealt with it already. And if you see this, this is a maxillary vestibular incision All right, let me just change a little bit about this image so that you guys can see it in a very particular proper manner. All right, now please have a look at this. So this is a vestibular incision that you see right over here. Open maxilla, then superiorly infraorbital rim. Over here, this is the floating maxilla. So of course, this is not a component or a compartment of a Lefort 2 fracture, but posteriorly, you have to plate the zygomatico-maxillary buttress with two L plates. And that is how you deal with a Lefort 2 fracture. On that note, please like us, please follow us, subscribe with us for many such more videos. We are Medi Study Go, and this is Dr. Sumit signing off from the Lefort 2 lecture. You're going to see me another time in a Lefort 3 lecture. Thank you very much for attending.